Today we'll be starting about this kidney health and delicious road to the kidney health. So what about all those things in detail? So we all know very well that in March 14th of March 2024, we have celebrated World Kidney Day, and March month basically we do celebrate our kidney month. Kidney month is a very important for all of us, where this year, 2024, the basic tagline of this kidney health, that kidney health for all and advancing, equating access to care to optimal medical health for the kidney health of journey, and to the practice of clinical nutrition, practice of clinical medicines, and also the lifestyle modification, counseling, and awareness to kidney health to all. So that is the motto, and that is the very important objective for celebrating Kidney Day and for the kidney health. And though I've been informed that the sessions of the BNL Live, we do talk about much more of inflammations. So in the kidney cases, we will directly down the lane, we'll be showing a lot of inflammations, a lot of cases, and also our core subject, the MNT, medical nutrition therapy and therapeutic dietary guidelines of kidney health. Next slide, please. So chronic kidney disease. So chronic kidney disease, it's a very important progressive disease that lost the ability to filter blood, concentrate urine, excess waste, and maintain the electrolyte balance. So if you think that kidney is basically our mouse kind of thing on computer, where in every 30 seconds, they work hard to remove any kind of waste, excessive, productions of the fluid and everything. And also, kidney not only performing the excretion systems in our body, but also it maintains our blood pressure. We all know, basically, a lot of students that they are of mine, we have know very well that we are a lot of talking about the RAS pathway, renin, angiotensin, aldosterone mechanism pathway, where we can see this aldosterone, this renin part, how come they're involved of the vasoconstriction, vasodilation, and to maintaining the blood pressure management. So not only the blood pressure management, but also the red blood cells management, the increase of occurrence of different infections, low calcium level, a lot of things can happen if kidney disease can come up. So the data shows that worldwide prevalence is estimated around 11 to 13% suffering from the kidney disease. In India, basically we are living as an India country, we see about 17 to 20% people are suffering from the chronic kidney disease. So our hospitals, we have seen a lot of patients used to get admissions for the AKI, acute kidney injury, those who are suffering from the chronic kidney disease. So that is very important thing to discuss. Next slide, please. So this pathophysiology. So pathophysiology of kidney is a very important thing, where we can say the renal tissues function. There are the few noticeable function in adaptations, and also there abnormality of any kind of thing, any toxin or any filtrations problem or any kind of there are a lot of complex things can happen in the kidney that can be suffer from the renal loss. Also the GFR will be disturbances, and lot of urea, creatinine, phosphorus, sodium, potassium, electrolyte disbalances can happen. So there is basically, we do check of the GFR, the glomerular filtration rate. When the GFR is less than 15 ml per liter per minute per 1.73 meters square, so basically the ability to dilute or concentrate the urine is lost, and urine osmolarity, because any kind of urinary infection of the CKD, we used to check the osmolarity and the renal osmolar load. So that's why this urea, creatinine are very, very important part for this kidney, because kidney basically perform the filtration, the ultrafiltration, and all those things, where we can see, where Dr. Harrison says of his book, that basically there are a lot of responses of reductions in the number of mediated by their vasoactive component, which is cytokines, growth factors, are very, very important inflammatory factors, are sometimes in distortions of the glomerular architecture. And this architecture basically disruptions of the filtrations, this barrier leading to any sclerosis and dropout of remaining of nephrons. So in this internal activity basically of the renin-angiotensin system. So the RAS system appears to contribute both this initial compensatory hyperfiltration and to the subsequent malabsorptive hypertrophy and the sclerosis. So this process is explained in why the renal mass and the isolated, any kind of, progressive is decline, the renal functioning. So pathophysiology basically we do describe apart from any kind of pathological conditions happens in the kidney are basically the pathophysiology. Next slide, please.
Yeah, ma'am. See, I have approved your request now. Yeah.
So what are the risk factors? So older age, the geriatric populations are much more susceptible to prone to have any kind of kidney infections. And family history is one of the major risks because we can't deny about our genetic factors, genetic disposition. That is one of the reasons. And urinary tract disorder that may increase the risk of the kidney damage, urinary tract infection, urolithiasis, kidney stones, renal calculi, or chronic urinary tract obstruction. So this could be one of the risks of this kidney functions. And also there are some systematic and medical disorders like diabetes mellitus, because we all know diabetes mellitus is basically a silent killer. This is a metabolic disorder, and diabetes basically happens in starvation amidst plenty. So in that case, if diabetes is uncontrolled, then people can suffer from diabetic nephropathy. And also hypertension, obesity, excessive alcohol usage, autoimmune disorders like SLE, systematic lupus erythematosus, and systematic infection like HIV, hepatitis C, and the atherosclerosis are also involved of disrupting the normal renal function, because we know very well this atherosclerosis, the plaque formations in the artery, basically the lot of excessive fat, excessive saturated fat, excessive alcohol, excessive trans fat can basically disrupt this pathway of this artery, can lead to the arterial problem, atherosclerosis, and that can lead to the kidney impairment or the normal renal function. This is one of the reasons. And also there are some nephrotoxic medication. If you talk about this, nowadays people are taking any kind of medications over the counter from any kind of pharmacies, because in India government is there, but there has to be a much more strict about maintaining of any kind of medication without prescription. So without prescriptions, people can take lot of ibuprofen, lot of drugs which are basically the painkiller without any kind of prescription, and prolonged usage and lot of repeated usage can lead to the renal impairment function and the kidney disease. And also there are some nephrotoxic like radiocontrast dye, because we know sometimes we do perform the angiography. So coronary angiography, sometimes they are passing kind of radioactive any kind of dye kind of thing, which is basically contrast-induced nephropathy. We can say the CIN. Basically, this is the factor for increasing urea, creatinine, and other renal function test parameters. And also there are some amino glycoside antibiotics, which are basically streptomycin and different kind of mycin, which are the prefixes, suffixes. In that case, they are very much, crucial, or we can say nephrotoxic medication responsible for the impaired renal function. And tobacco smoking, we try to say avoid tobacco is zero. So no form of tobacco, not even cigarette, not even any kind of quinine, any kind of packaged tobacco, nothing. So nothing should be there for this tobacco smoking. So tobacco smoking shouldn't be there. Next slide, please. So symptoms, basically this is whether it's a kind of a idiopathic thing. Sometimes symptoms can occur, sometimes there is no symptoms unless and until we can do the renal function test and also the electrolyte test, or sometimes we can perform any kind of USG, ultrasonography of the whole abdomen. So chest pain is one of the symptoms, dry skin, increased or decreased urination, loss of appetite, muscle cramp, feeling tired, headache, shortness of breath, sleep problem, vomiting, weight loss are the symptoms. So we shouldn't, avoid any kind of symptoms, whether it's mild, whether it's moderate, whether it's major. We should head to our doctor and a clinical dietitian for their medicines, their diagnostics pathways, and also their medical nutrition therapy diet prescription from a clinical dietitian. Next page, please. So stages of CKD, where I already have mentioned that GFR is one of the indicators for maintaining the stage 1, stage 2, stage 3A, 3B, 4 and 5, where stage 5 is to call basically kidney failure or end stage kidney disease. So in that cases, dialysis will be one of the options for that. But
you are muted. Dr. Aritra, I can't hear you.
Anybody can hear me? Is my voice audible? Okay, fine.
You are audible.
Ma'am, can you hear me? Saloni, ma'am?
Yes, you're audible, Aritra ji. Go ahead.
Okay, fine. Okay, I'm just going ahead. Yeah. So normal and functioning kidney, that less than 90 ml per minute is less than 90% for the kidney function. Mild decrease in the kidney function, 60 to 90, 89 basically, 60 to 89%. Mild to moderate, 45 to 59. Mild to moderate decrease, 30 to 44, and 15 to 29. Severe decrease in the kidney function, 15 to 29%. So basically, being a clinical dietitian and clinical nutritionist, our function when the patient used to come to such kind of renal problems or in kind of status of the kidney, we should guide them with the proper dietary modification and what could be the diet is. When I will discuss about the dietary pattern, then I will talk more about the protein and more about the other major parameters too. Okay, so next slide please. So what are the complications of CKD? There are a lot of complications can happen when the CKD can come up. So cardiovascular disease is one of the major complications. So patients with the chronic kidney disease, basically that's elevated the cardiovascular risk, maintaining the coronary artery disease. And basically we sometimes neglect about the heart failure. So just let me speak about one line about the heart failure. The chronic heart failure that they are basically we used to call the CHF, the heart failure. This is sometimes different from the heart attack, because heart failure means when the ejection fraction are basically less than 40%. How could we check? We can check after doing the echocardiography. So LVEF is less than 40%, then patients suffer from the heart failure. But sometimes we try to ambiguate this heart failure and the heart attack. Heart attack is sometimes different, because heart attack means when the oxygen, nutrients and other things that can't able properly goes to his artery channels, and they're problematic for the cardiac muscle death. So that is something different. So coronary heart failure is one of the major complications after suffering from the CKD, and also with this elevated CKD stages is 1 to 3 basically capture the general population, and in that cases the chronic pro-inflammatory stages contributing the vascular, the myocardial remodeling, this problem resulting of the atherosclerotic plaques, vascular calcification, vascular senescence, myocardial fibrosis, calcification of the cardiac valves. So these are the complications of the CKD. Is one of the major complications, that is heart disease or stroke. So that is the very important thing. And there are a lot of medications. Are basically what I said is that kidney and the heart are working as a brothers and sisters. Sometimes in the heart failure, the modern major drug is ARNI, angiotensin receptor of neprilysin inhibitor. They're working very rapidly with the RAS pathway. Maybe they're working with the angiotensin converting enzyme inhibitors, the AC inhibitors, or the ARB, or any kind of like beta blockers and all. And also there are kidney functioning is sometimes disturbed with the drug with the mineralocorticoids antagonist receptors. MRS basically spironolactone, aldactone. So these kind of drugs sometimes basically doing the ambiguity between the heart problem, kidney problem, and disrupt of the RAS pathway and giving the haywire kind of thing. And also the high blood pressure. So definitely blood pressure means this pressures of the blood, and this control by again this RAS pathway when the aldosterone also cause our kidney to release to excrete in potassium through our urine, and the increase is sodium in our bloodstream causes the water retention. So too much of water retention can increase the blood volume and the blood pressure, and that can compromise the RAS. So that is very, very important, very obvious. Those who are suffering from the kidney disease, so high blood pressure is one of the major complications can happen. Anemia, low level of red blood cells. We know the half layer, the 120 days basically. And in the people with the CKD often have the more the causes with the kidney damage to produce less erythropoietin. EPO, this is basically a hormone that signals to our bone marrow like a spongy tissue that inside most of our bones to make the red blood cells. So sometimes this is disrupted due to the lower kidney function or impairment of the renal function. Metabolic acidosis, build up in the acid in the blood. So due to the increase of the excretory capacity and the high level of endogenous and exogenous acid, develops in our kidneys. So basically they are incapable of excreting the acid load, resulting in the low point in the hydrogen, carbon dioxide and all. And there's sometimes, this renal acidosis or metabolic acidosis can happen, and that can increases the calcium reabsorption from the bones, osteomalacia, osteodystrophy, the rapid correction of the acidosis where the calcium redisposition can happen in the bones and the titany. So in that cases, metabolic acidosis is one of the major complications of the CKD. So mineral and bone disorder, very obviously when the blood levels of the calcium and the phosphorus, because in renal diet, once we always check care about the calcium and the phosphorus level. We try to restrict the high phosphate or high phosphorus food in our diet. So balance leading to the bone and the heart disease. Hyperkalemia, high levels of potassium in the blood is very obvious. If you think about the physiology of the nephron function, the first one is yes, I will come these questions later on. Very good. Please keep on writing your questions. I will come one by one the answers after finishing the session. So hyperkalemia, the high levels of potassium in the blood. This is the first thing, because if we check about the first one is the proximal convolutional tubule, then it goes to our Henle's loop, and third one is the distal convolutional tubule, but the RAS pathway basically happening over there. And in that case, the hyperkalemia is a major electrolyte problems can happen with the CKD complication. And sometimes in our hospital cases, we can see the hypoalbuminuria. Hypoalbuminuria is one of the major complications can happen once they suffer from any kind of kidney problem. Next slide, please. Dialysis is basically the end-stage kidney disease or end-stage renal disease. Dialysis is one of the major options that we can perform. One is hemodialysis or one is the peritoneal dialysis. So hemodialysis, basically the fluid electrolyte content is similar to that the normal plasma, so where we can maintain the diffusion. Can you please mute your slide, Mohammed Abdul? Anyway, so diffusion, there's the ultrafiltration and the osmosis from the blood into the dialysis are removed. So what are the complications we can get? Hypotension, electrolyte abnormalities, hypokalemia, lot of infection, lot of nosocomial infection can happen. And peritoneal dialysis, when a catheter is implanted surgically through the abdomen and into the peritoneal cavity, so high dextrose concentration is installed into the peritoneum. So complications would be peritonitis, hypotension that requires fluid and sodium replacement, and the weight gain can happen in the process of the dialysis. So hemodialysis and peritoneal dialysis both can perform, where hemodialysis is a little costly, only under the hospital supervision it can perform, but sometimes people are doing peritoneal dialysis at their home with the proper care and the proper management from a person who can perform a dialysis technician. Okay, next slide, please. So World Kidney Day, already have mentioned, this 14th of March, we do celebrate World Kidney Day this year. So awareness, the big global attention to the importance of the kidney health are very, very, very important. Next slide, please. Meet your profile, Mr. Next slide, please, Vishaka. So eating right, next slide. Next slide, please. So eating right for the kidney. So what would be the dietary pattern for this kidney disorder? So nutrition plays a very pivotal role and very vital role in the management of patients with the CKD, especially the end-stage renal disease patients. So in that cases, a tailor-made, calorie-calculated, customized therapeutic diet calculations would be the key for those who are suffering from the renal disease, whether the patients suffering from CKD1, CKD2, CKD3A, 3B, CKD4, and also CKD5, the end-stage renal disease. But my suggestions to all of my students who are attending this session and also of my juniors, that you have to follow the diet calculation in front of the patient, and that should be a tailor-made, and that should be with the maintaining proper A, B, C, D, those who are basically suffers from a kidney disease, because a printed diet prescription wouldn't be suffice for a patient who has CKD, because everyone's metabolic health, everyone's blood biochemistry are not same. So diet restrictions and compliance and adherence with the therapy, malnutrition, wasting, and inflammation are very important. And what I have mentioned, hypoalbuminemia, that is one of the very, very important part that has to be catered off. Next slide, please. So what I will say that giving up this constitutes a healthy diet is difficult to comprehend. Type 2 diabetes or CVD adds further restrictions or the conflicts with the renal diet. Patients give priority to most prominent illness to sense the giving up, and patients adopt a self-defined diet perceived to be a reasonable and healthy. So in that cases, for the CKD suffice patient or CKD suffering patient, there are a lot of people who are the non-medical persons, meaning those who are practicing the quackery things, they can say the protein should be zero for any kind of kidney patients. And there shouldn't be any kind of animal product, there shouldn't be any kind of shark product, there shouldn't be any kind of fruits product that absolutely meets and that absolutely taboos, or that absolutely, this is the bridge the gap that this kind of sessions can come up with the brain and life, that protein should be there. The protein should be there, and the calculations would be 0.6 to 0.8 gram of protein per ideal kg body weight. Those who are suffering from the kidney disease, I'm talking about the kidney disease non-dialysis patient. For the dialysis patient, the protein part will be 1 to 1.5 to 2 grams of protein per ideal kg body weight. So in that cases, that is very, 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 very important and very primordial thing, and it could be a holistic approaches that we have to counsel to our patient in detail about the diet. So, and also what we can see in geriatric population, that frailty, sarcopenia, muscle wasting, negative nitrogen balance, low chemical score, low atypical percentage. So these are very common. So we have to always take care about the atypical percentage, net dietary protein intake, what we have studied in our advanced nutrition, and also we do take care of the chemical score and the high biological value protein. That should be the key to take care of the kidney's health. Sometimes we do talk about the like branch chain amino acid. So branching amino acid, basically we can talk about the isoleucine, leucine, valine. So basically predominantly these can use for the liver patients. But kidney patient, that will be again beneficial for them. We try to restrict much more of the aromatic amino acids. So aromatic amino acid predominantly we can get from the red meat, we can get from the meat extracts, we can get from the liver, different of the meats and all. So that shouldn't be given for a patient who are suffering from the CKD 1 to CKD 4. So in that cases, that is very important. Next slide, please. So, and also the prepare food, the less sodium. So this page, basically this pictorial page are showing the nutritional facts. Basically, once we purchase any kind of packaged food from the outer dietary sources or any supermarket or any kind of market, we always see the frontal part. So frontal part basically a eye-washing thing that can attract the consumers, that can attract the customers. So the back page will be the base part that we have to read out the labeling. The food labeling are very important. So we definitely opt for the low sodium salts and the low sodium food products. Avoid any kind of high sodium foods like salt, like seasoning, like pickles, like sauce, like ketchup, like ready to eat, any kind of baked product, breads product, loaf products or anything. Because again, we have already discussed that high sodium diet or high sodium thing can increase your blood pressure, because too much of sodium basically helps to water retention in our body. And we can see the aldosterone part from the renin, angiotensin, aldosterone pathway and excrete the potassium part. So sodium can involve into our body and that can lead to edema. So edema, pedal edema or ascites like pulmonary edema are very common. That's why sometimes doctor and sometimes we the clinical nutritionist, after checking the patient, we try to restrict the entire fluid intake. What about the fluid intake? Basically we do calculate of the fluid intake and urine output. So accordingly we have to calculation the fluid intake and to prescribe to our patient. That is your 24 hours fluid intake chart or monitoring chart. In the hospital cases, we can see in daily, but in the home patients or the OPD patients, so we basically do the telephonic conversations, or sometimes any sister or any brother could help us to walking integratedly for monitoring the fluid balance. Next slide, please. So eat the right amount, the right types of protein, animal protein foods, chicken, fish, meat, eggs, and dairy. Plant protein, pulses, legumes, sprouts, soybean, beans, nuts, and seeds. So basically in the chart, we can see all the food groups are there. And what among the food groups we can give? Patient may be non-vegetarian, patient may be vegan, patient may be vegetarian, patient may be lacto-vegetarian, ovo-vegetarian, or lacto-ovo-vegetarian. In that cases, how could we calculate the protein according to their NDPcal percentage, chemical score, and biological value we try to prescribe. So in that cases, chicken, we can give fish, we can give egg, but dairy products not we try to allow to the raw milk to the patients, because milk contain high phosphorus. So in that cases, we should avoid the dairy product, but for avoiding the dysbiosis or any kind of gut microbiota problem, we try to give them curd, we try to give them buttermilk, but again maintaining the fluid balance. Again, pulses, legumes, sprouts, soybean, beans, nuts and seeds have an exclusively good amount of antioxidant, exclusively good amount of the flavonoids. So we can give to the patients, but again, the calculation part is very important. And also these antioxidant and flavonoids try to reduce the free radical and reactive oxygen species, the ROS. So it could be beneficial for the patients. But again, that shouldn't be any no or any cross, but again, it depends on the calculative way we can give to the patients. Next slide, please. So choose healthy fats. Minimize the usage of the excess oil, butter, ghee. Eat healthy fat, fish, nuts, seeds, walnut, flaxseed. Opt for low-fat or fat-free milk, yogurt, and cheeses. There is no fat-free milk. There's a wrong in the slide. Low-fat milk would be there, but there is no many kind of milk. Is the fat-free. So basically, we know very well that MUFA and the PUFA plays a major role for maintaining the essential fatty acid, like essential amino acid we can get from the protein. So MUFA and the PUFA, the ratio would be 1:1. We can use any kind of oil that's a low smoke point, not too much of the high smoke point. Again, too much of the high smoke point can increases the free radical and reactive oxygen species, can dramatically increases any kind of syndrome X and non-communicable diseases. So oil should be there, but shouldn't be excess oil. The simmering, broiling, boiling, shallow frying would be opted for the patients. Butter and ghee, again, these are under the saturated fatty acid. Ghee contains the short-chain fatty acids. So in that cases, we can give a very little amount to the patient, but those patients are vegetarian patient. As half teaspoon of ghee can be offered for the patient, and for the MCT, medium chain triglycerides, we can offer the butter. But again, palmitic acid, palm oil shouldn't be there of any kind of fats, because there is a myth that only high fat would be our enemy. But carbohydrate is okay. But sometimes we can say sometimes high fructose diet would be detrimental for our health, because you can see any kind of patients which come to you with the CKD, they have anemia, number one, or they are having any kind of uricosuric drug, that is febuxostat or any kind of drug. They are suffering from the hyperuricemia. So hyperuricemia, we basically talk about, if you look about the biochemistry, the purine, the xanthine oxidase, the uric acid metabolism, monosodium urate, MSU crystals, too much of pain, overnight pain, inflammations like burning sensations can happen are the symptoms. But apart from that, sometimes fructose, the modern research says, there are a lot of PubMed Indus journals been published, that fructose would be the much more higher detrimental than the purine for the uric acid metabolisms. Not only that, we can see if we can use the fructose with the proper management, the way like fructose, then after Krebs cycle and through the cytochrome A, B pathway, the electron transport system chain, and we can try to engulf to ADP, to the ATP formation. But sometimes this fructose can goes to the de novo synthesis pathway, and that increases the like palmitic acid, then monoacetyl, diacetyl, and triglycerides. So triglycerides are responsible for too much of sweets, too much of fruits, and too much of fructose-based diet. So that's why carbohydrate, again, a calculable thing, because in the kidney cases, we try to restrict the mevalonate pathway, where squalene try to restrict with HMG co-reductase, basically the drugs that the any kind of statin, rosuvastatin, atorvastatin, we are basically doctors used to prescribe after dinner. So that is again the cholesterol management. So in that cases, fat is a very important thing. We shouldn't neglect fat, but again, the balancing and the proper calculation would be the key for the managing of any CKD or kidney problems. And also, trans fatty acid shouldn't be there, because we know hydrogenations of the fat can increases lot of liquid to the solid temperature, can increase the trans fatty acid. Too much of cookies, too much of fried, samosa, kachori, too much of namkins, and also margarine has a high trans fatty acid, vanaspati also. So we try to avoid. So our saturated fatty acid less than 7%, monounsaturated fatty acid 10 to 15%, polyunsaturated fatty acid less than 10%, and negligible trans fatty acid. So that's why that the chart of the food labeling, any kind of food things that you are purchasing from the outside food shop, they have to properly read. So healthy fats already we have discussed. So low fat milk like double toned milk, like skimmed milk, that can be opted, and that can be, we can make some chena, we can make some curd, it's okay. But again, considerations in our mind to that the fluid balance, because too much of curd, too much of buttermilk, too much of lassi can again lesser intake of the normal water in our body. So that's why it's very important thing that we have to take care of. Next slide, please. Choose foods, drinks with the less phosphorus. Yes, that is very important. Fresh fruits and vegetables, bread pasta, corn rice cereals, light colored sodas, pop up. Try to avoid a lot of high fructose corn syrup, lot of carbonated beverages, lot of beverages which are actually the aerated things from the outside market. Meat, poultry, fish, too much of dairy fruits, too much of the dark colored sodas, punch, bottled, canned have added up too much of phosphorus. So maybe dates are beneficial, palm dates are beneficial, jaggery are beneficial, but due to the high phosphorus level, we try to restrict. My suggestion is to restrict, not too much of avoided. Once in a blue moon, once in a fortnight, or once in a month can have the taste of any kind of natural sources of the foods, but that should be properly organic. But nowadays there is a fancy trends are going on from the quoted, unquoted organic foods. Organic things are there. Organic things are decades after decades. Salami ma'am is there. I think she's a motherly figure of us. So she has seen that times also farmers are cropping the organic products also. Or nowadays, because of high fashion things, people are going to the organic things. But no, everything are organic. But we should always keep our eyes and ears on for purchasing. We try to avoid any kind of artificial color which are non-permitted, any kind of artificial preservative, artificial additive, and also any kind of toxicity. So that is very important thing, because food groups are very, all those things about the food groups, but what about the food groups? What about the cooking mechanism? How to cook, when to cook? That is very important thing for any kind of things which have the high phosphorus or less phosphorus. Next slide, please. Vishaka, next slide, please. So choose foods with the right amount of potassium. That is very important thing. Eggplant, carrot, white rice, celery, peas. These fruits are there. These vegetables are there. Apart from that, which is the high potassium vegetables are available in the market. So basically, there are three segregations are there. 0 to 200 mg of potassium per 100 gram of the food servings are allowed, but more than 400 mg. 400 mg potassium per 100 grams of food groups, try to restrict. Now our patients are very kind of, apathetical, very loss of appetite, having nothing. So eating have up to a little bit of, palong shak, that doesn't make any differences. But if our patients have anything, everything, and the diet is properly okay for maintaining the chrononutrition pathways kind of thing, she and he should be restricted the potassium. But those patients with very fatal condition, having nothing, so they can have a little bit of potassium. That doesn't make. Again, that's why I'm saying that tailored made and person to person, the CKD diet prescription would be the key. Not a common diet prescription, Xerox print out and giving like a distributions. This is not the rule of our clinical dietetics. Next slide, please. So renal diet compliance are arguably most restrictive for any patient group. CKD patients need to comply with the diet restriction, proper medication, regimen, and the fluid restriction. 20 to 80% are non-compliant with the diet restriction. So non-compliant shouldn't be there. Patient should be compliant with the diet therapy. They has to adhere. Sometimes 100% is not possible, but 60 to 70% to 80% can possible, because in our dietetics, we try to treat our patient to the proper renal diet. But the ones patients, outside our hand, some doctors will be there, so the nephrologist will be there. They try to give the patients for the dialysis either, or sometimes they can patients to go for the renal transplant. So transplant will be the majorly functioning available in the India. But our objective, our goal to treat our patient monitoringly to make the maximum compliance to a proper empathetical counseling to the patient. So compliant to patient's quality of life, this is number one. Life expectancy is much more higher. Medical complications are lower, and the risk of symptoms are lower. So in that cases, these things should be high, and those medical complications, the risk of symptoms would be the lower. This could be our objective to treat our patients. Next slide, please. Next slide. So current recommendation, the ESPN guideline, calories 35 kilocalorie per kg, gap of 960, the average daily intake 24 to 25 kilocalories. and protein 1.2 gram per ideal kg body weight. So that is the ideal kg means we have to do the proper Broca's and the BMI calculations, and then you have to prescribe gap of 16 grams per day, average daily intake 1 gram. Next slide, please. So this is a very important thing that majority of patients who suffers from the kidney disease, in that cases we have to take care of these guidelines about the calorie. So calorie CKD 1 to 4 and the CKD states they have to, what amount of calorie they can take. So more than 60 years, less than 60 years. So that should be the key, and accordingly we have to calculate to our patients who are suffering from the kidney disease. So we have to give a proper calories, because CKD patients again and again I am saying that the high energy needs, the calorie will be higher for the negative nitrogen balance, sometimes cachexia, sometimes muscle weakness, sometimes sarcopenia, and for the geriatric patient, frailty could be there. Next slide, please. Protein recommendation for the CKD 1 to 4, low protein diet is recommended to alleviate stress of the kidneys. And stage 5, the high protein diet, because in dialysis patient, basically we have recommended to compensate for the 10 gram to 12 gram protein free. So in that cases, many foods high in protein can also be in the high in phosphorus. So in that cases, we try to maintain that CKD 1 to CKD 4 and CKD 5 to maintaining the ESPN and EBPG guidelines properly for maintaining the protein part. Mean dietary protein intake at 1 gram per kg per day. That should be the key. Next slide, please. High protein diet for the dialysis patients. Yes. 35 kilocalorie, 65 obese patients, 35 kilocalorie, SPN guideline 35, EPPG guideline 30 to 40, and sodium, there is a list, no guidelines, fluid, there is no guideline, potassium, SPN like 2000, 2500 mg per day, EPPG that is 1950 to 2730, phosphorus is 800 to 1000 mg per day, ASPN 800 to 1000 mg per day, and EPPG is basically 800 to 1000 mg per day, and the calcium recommendations would be the key. So in that cases, you can see our doctor's prescription. You can see there are a lot of drugs being prescribed. The drugs are basically for the kidneys. Drugs are basically heart. If a patient suffering from diabetes drug, hypertensive drug, some kind of blood thinner will be there, and also there are the drug are calcium, vitamin D3, and also there are importance of the drug for the lowering the uric acid, and sometimes if his hemoglobin is not corrected, sometimes they can go for the hemoglobin shots like IV for the patients. Next slide, please. Dialysis by 6 days. Next slide, please. So protein recommendations are designed to compensate for the 10 to 12 gram free amino acid loss per dialysis treatment. So in dialysis treatment, basically there are loss of amino acid because we know the dialysis pathways, and in that cases, mean dietary protein intake 1 gram per kg per day will be there, and 1.2 gram per kg per day, and 50% from the high biological value protein. SPN guidelines 1.2 to 1.4, and EBPG guideline 1.1 kg per day would be recommended for the dialysis patient. So after dialysis patient, we have to check their weight, and also we have to give a good amount of the high protein. Maybe sometimes supplementations are there, so we can give to the patients directly. Next slide, please. Phosphorus recommendation, hyperphosphatemia generally does not occur until GFR is 20 to 30 ml per minute, and serum level varies depending on the dietary intake. Patients with a GFR is less than 60 may require some dietary intervention or monitoring. Treatment of the hypophosphatemia includes dietary phosphorus restriction, use of phosphate binders, and clearance of the phosphorus through the dialysis, where again 800 to 1000 is spent 800 to 1000, and EPPG 800 to 1000 mg per day would be the recommended phosphorus for the dialysis patient with stage 5 end-stage kidney disease patients. Next. Calcium recommendation, calcium balance is again determined the calcium intake, and the vitamin D therapy. Dietary intake is often limited by the limitations of the high phosphorus dairy fruit. Complications occur when elevated serum calcium and the phosphorus precipitate, leading to soft tissue calcification and accelerations. Because whatever we have discussed about the acidosis, we did talk about that calcification, soft tissue calcification and acceleration, which can involve with the cardiovascular complications. So 2000 mg per day will be the recommended, 2 gram per day. Next slide, please. Potassium, as CKD progresses, potassium retention, hyperkalemia occurs, contributing to elevated blood pressure and cardiac irregularities. Potassium allowances varies depending on the urine output. Recommends are approximately 40 mg per kg edema, like body weight, and hyperkalemia may occur at this level in patients who are anuric or have constipation. Urea is not properly there and constipation is there. In that cases, hyperkalemia may occur. In the case of the high potassium, sometimes we can give the K-bind, and with that also the potassium restriction food we can give for the patients who are suffering from the kidney disease and also the CKD5 dialysis patient. To ASPEN guideline 2000 to 2500 mg per day, and in EPPG guideline 1950 to 2000 mg per day would be the recommended. Next slide, please. Sodium and fluid intake is individualized based on the fluid gains, blood pressure control, and residual renal function. Sometimes doctors or physicians or nephrologists used to give the furosemide or sometimes loop diuretics and all the kind of things they used to give. So in that cases, sometimes edema, fluid balance, blood pressure control can give him. If the blood pressure falls down, some kind of vasopressions are going on. So residual renal function, if the patients are often non-compliant with the sodium and fluid restriction, then other NSAs going on. So in that cases, that should be depend on the dialysis
Mr. Khan?
process.
Mr. Khan, can we hurry up so we have more time for discussion at the same time?
Sure.
Yeah?
I think
Thank you very much.
Yeah. So ASPEN guideline 1.8 to 2.5 gram, and the fluid is 1000 ml plus the urine volume. So fluid intake and the urine output should be the properly monitoring up there. Next slide, please. Low protein diet, free diet patient. Next slide, please. Already we have discussed of these things also. Next slide, please. 35 kilocalorie per day. Next slide, please, Vishakha. Protein is 0.6 to 0.75. High biological value protein already have discussed that according to the GFR rules, we can increase the protein. Next slide, please. Phosphorus 800 to 1000, 600 to 1000 for the CKD patient. Next slide, please. Potassium, again important for the potassium changes, medication that change the level of the potassium, sometimes in the low potassium, in case of the dialysis tube patient, the KCl infusions are going on, and the patients are on the orally can have, then pot chlor with the fruit juice are going on for the hypokalemic patient. Next slide, please. Potassium recommendation, non-dialysis patient, high potassium fluid, banana, orange, potatoes, tomatoes, and all those things. Next slide, please. Sodium recommendation, fluid and electrolyte balance, and should be based on the blood pressure and the fluid balance. Sodium is one of the key parameters for the electrolytes. Next slide, please. Non-dialysis CKD is a protein, phosphorus, potassium, sodium as a whole, as a peanuts kind of thing. We can get in detail of in the ASPEN guideline and also the DOQI guideline. Next slide, please. Fiber recommendations are very important. 20-25 grams per day fiber intake should be there, because high dietary fiber intake associated with the decreased inflammation, because we will talk about a lot of inflammation like cytokines, IL-6, interleukin factor, TNF-alpha, and everything. In this case, high fiber diet will be good for the patient who can suffer from constipation and other dysbiosis problem, because we tend to have lot of PPIs on daily basis. That can one of the major reasons, and also the drug would be the reasons. And also the resistant maltodextrin like amylopectin and all would be the key for maintaining the proper dietary balance, acts as a fructooligosaccharides, the prebiotics, work with probiotics or symbiotics for our gut. So fiber recommendations is good for those who suffer from the kidney disease. Next slide, please. Micronutrient are selenium, zinc supplementation, anticoagulant medications, vitamin K supplementation. Once you go for the any kind of blood thinner, we try to restrict the vitamin K. But anticoagulant medications, we can go for the vitamin K supplementation. Next slide, please. Vishaka, next slide. Vitamin A, E, vitamin D are very, very important. Next slide. Can significantly outcome for the albumin level is very important thing, because albumin level are maintaining this the oncotic pressure, and also edema is one of the responsible for the lower albumin level. Sometimes patients for the hypoalbuminuria level suffer from the hypoalbuminuria. In that cases, we can give some supplement, we can give some oral doses, we can give some egg whites and other things which is predominantly have the albumin level. Next slide, please. So that's it for the presentations in detail about this renal health consequences and also mentioning for the kidney. Thank you so much for your questions listening. Thank you for inviting me for such a lengthy session. Thank you.
Thank you very much, Mr. Khan. It was indeed a detailed and wonderful based, practical, theoretical based discussion which we had. And I am very happy to note that there are so many participants who have joined who want to interact, and they are keen to ask questions. And sorry that I interrupted between to tell you that we need to discuss more questions. So I would also like to have Salome ma'am, if she's there, to join the discussion, and also Nazni, Hussain, Richa, if they are there. I'll start asking questions according to what participants have discussed. One is case-based, and we always look forward for case-based discussion in these kind of sessions. And I'm glad that one of the participants, Halima Nourain, has asked about a case which she feels that needs to be discussed. A 62-year female diagnosed with high bilirubin with 30 milligrams severe bilirubin is 30 mg per dl. She's with autoimmune hepatitis and AKI. Creat was 7.5. She wants to understand autoimmune, deranged LFTs, high creat, what could be the reason? She is leading an active lifestyle. She is non-diabetic. She should have been on renal diet from now, or she can follow a normal diet. Over to you,
yes.
Mr. Khan.
Very good questions. Very good question. Thank you, Dr. Geeta. And I think Halima, I do address your question that 62 years female diagnosed with this high bilirubin. So we can see that bilirubin means the liver function test is it's hampered because 30 mg is much more higher. So we have to check the total bilirubin, conjugated bilirubin, and also the OTPT, SGOT, SGPT, and other enzymatic factors. What are the reasons? The reasons would be for, you have mentioned the autoimmune hepatitis. So autoimmune hepatitis means there are a lot of things can happen because these things are very idiopathic. So autoimmune disorders can happen from any kind of thing. There may be some different mutation, there may be some genetic prognosis, there may be some DNA, RNA, and there are a lot of other reasons can happen this autoimmune disease. And patients with the AKI, acute kidney injury, and the creatinine was 7.5. So due to the liver thing, so what we can see, the liver functioning will with a lot of the scapula cells are there, and the word liver are the very largest organ in our body. So maintain all the metabolic activity, metabolites activity like carbohydrate metabolism, protein metabolism, fat metabolism, vitamin metabolism, and also the minerals metabolism. And also we can see that urea basically produced in the liver. Maybe urea working in the kidney and other things, but urea basically the produced in the liver. And when we can see the other cycles like glycolysis, the Krebs cycle, the pyruvic acid cycle, everything that happens in the liver. So sometimes liver to this metabolism is disrupted because liver is already destroyed due to this kind of even hepatitis problem. And in that cases, if it is disrupted, so that can again, this is a hamper a load to the kidney. If load to the kidney, urea is not properly maintaining, not properly producing in the liver. In that cases, renal would be the major thing can hamper to this kind of liver problem. And the creatinine liver is elevated is 7.5. Now this 7.5, our goal to treat the patient with the low protein 2 criteria after seeing their body weight, because the patient is 62, means a geriatric female, and we have to take care about the osteoarthritis, osteoporosis, the frailty, muscle weakness and everything, because he's a post-menopausal patient and 62 years female. So in that cases, checking all the criteria, body weight, body height and also the other clinical parameters, we have to take care of the diet. Yes, predominantly, if the dialysis is not happening by the nephrologist or by the clinician, we try to restrict the proper guideline of the CKD 3A or 3B, which category, because I don't know what about the GFR. So we can fall to the patient and we can start treating the patient. So again, I am saying that the heart, the renal angiotensin pressure, the pressure and the liver all are connected with the kidney, because we shouldn't forget about the urea cycle. So that is very important of the kidney function. So urea, creatinine are the major important parameter once you perform the renal function test.
Yeah, thank you for that discussion. Salome ma'am, would you like to comment on this? Because one question follows for this case by Halima Nurain is, can we give egg white when total bilirubin is 3 grams? But remember, the creat is also 7. So
Yes.
over to you. And also if Salome ma'am can discuss about this case, what she has to say, it'll be nice. Over to you, Aritra ji. First, you can discuss about egg white question, and then I think we will ask Salome ma'am to talk about this
Yes,
case.
because we don't know. I don't know about what about the albumin level. Okay, if the patient is suffer from the hypoalbuminuria, again, albumin is one of the major parts of the liver. So in that cases, we can give the egg white, but not more than, because if a egg white, hence egg white, the protein particularly 6.5, 6 to 6.5 grams of protein. So if you give a patient a 30 gram or 25 to 30 grams protein per day in total. So in that cases, one egg white can be given to the patient, or the patient is suffer from the any kind of hypoalbuminuria problem, we can give the 2 egg white also. But also you have in the albumin care powder, we shouldn't discuss any kind of products name over here. Any kind of nutraceuticals or the clinical nutraceuticals we can give under the supervisions with the dietitian, because oncotonic pressure and other important parameters are the key factors for giving any supplement, and the supplement or the clinical food should be the proper research based, and also their publications should be there, because unless and until there are a lot of supplements are available in the market, but every supplements are not efficient to the patients.
Great. Salome ma'am, would you like to say something about this case? Your inputs and your opinion about this case?
Thank you, Gita. Actually, I didn't hear the case. I was away with.
Okay. So just a simple question put to you about this case, ma'am. If you have a renal, autoimmune, and liver, 3 areas where you need to work on, what kind of diet prescription would you look at? A normal diet or a CKD diet? Would you like to restrict the proteins and take care of it, or a normal diet?
So, if the CKD stages, of course, we will have to see if the patient is first time diagnosed with a creatinine, because generally when there is a liver or any hepatic condition, your renal sufficiency also goes down. So I think we will look at, in general, both liver and kidney. Will not stress on kidney at all, and first we'll improve the liver functions, and that is more important here in this case. And she's an elderly lady, so how will you reduce the excretion of the bile and reduce the bilirubin? That will be the first thing. Protein can be given 0.8 grams safely. That can be given. What you were saying about the egg whites also can be given. There is no harm, because there is a lot of BCAA coming from egg whites, and we should be giving it. So I think we will not stress on the renal if there is a normal urine output. If the urine output is normal, I don't think I should be worried about the CKD grade, and if the eGFR is also not a concern. So we will give liver specific, a good high protein, I can even go up to 1 gram protein. If there is a proteinuria, if there is a low albumin, I don't know whether you explained
Yes,
low
yes,
albumin.
yes.
Then
Because
Yeah, he
if
can.
albumin
that
level is not mentioned properly, so in
if
that
there
cases we have to
no,
check.
not
Yes,
mentioned,
we have to check,
there
not
is
mentioned. And what Saloni ma'am said about this branching amino acids is very important, because branching amino acid would be the key factors for the any kind of liver patients or NAS patient or any those patients suffer from the liver disease. And we try to restrict the aromatic amino acid like phenylalanine or any tyrosine or any
Dr.
in other things. So we should avoid the aromatic amino acids.
We'll
Yes.
take your comment. Let me just finish with the case, because this is a platform where we discuss case-based dietetic application. So that is important, because the recommendations, all that is there. But how do you apply that to a particular case? So that's what we are looking at in this case. If there is no urine output, no albumin levels, no EGFR, still you can simultaneously do, but concentrate on bringing the bilirubin down, improving the liver function. So
True.
that's another thing, how as a nutritionist we all know how do we bring the bilirubin down. Okay, so we will give extra fibers which will excrete the excess of bilirubin, and it will come down. If there is any obstruction, then it's a different issue. So we will have to look into the reason for why this bilirubin is high. Yes, if it's autoimmune hepatitis, then again a different, altogether a different ball game. So I think symptom specific. If I have a nutrition diagnosis, I will assess the patient. I will put my nutrition diagnosis, and I will try to treat each symptoms, alleviate symptom base. So if my concern is the bilirubin first, then I will treat that first. Okay, if there was anuria or urine, I would have combined that and I would have restricted the fluid end. I do not know. Also, if there is no edema history, but as a nutritionist, I will take the history. How long the patient is suffering? When was the first increased bilirubin was, you know, when did we have that first report? So after thorough screening, using a validated nutrition screening tool and your assessment, plus the nutrition focused physical examination, which is very important. So which you should do, and then one by one symptoms you will have to tackle it. That's how you should do it. Don't go for CKD, don't go for only liver. You be standard. And one by one alleviating symptoms, I think the patient will feel much better and the feeling of well-being will come. Thank
Yeah,
you.
thank you, ma'am.
Thank
Thank you,
you.
Mr. Khan. Actually, that's what I think when you say it's liver or kidneys output, urine output, EGFR, all that needs to be noted. Albumin needs to be noted. Then only you can prioritize your areas of nutrition diagnosis, and that's what is being quoted by our both the experts here, Madam and Mr. Khan. There is a lot of questions about albumin, and I want Kasoli ma'am and you both to discuss about it. So generally there is hypoalbuminemia, or in kidney diseases a lot of albumin supplements are recommended. So would you look for a albumin supplement or a whey supplement? How would you look for it? Also, they have said that patient actually is a geriatric patient, 70 years old. Again, same case, high LFTs, liver enzymes are high, albumin is very low. And in such cases with CKD5, do we really go for an albumin supplement or a low protein or a whey protein?
So to address this question, first of all, if there is no edema, there is no need of giving IV albumin for oncotic pressure, but we can give dietary albumin, that is any protein source which is concentrated in egg albumin. So you can use it because it will give you BCA also, and it will help the patient. So to address this issue, we will have to definitely, because albumin can be fatal, low albumin. So therefore, we need to treat this. We need to give albumin supplement. If patient is able to eat 2-3 egg whites, or I will even give one full egg also. I don't mind with the yolk, because to improve the protein and availability. Another thing is generally we don't give IV albumin unless there is edema and unless we want to use it for a oncotic pressure. In renal patients, we do use it, but another thing is I would also use essential amino acids, which will in turn bring this levels, at least it will bring it, elevate it little. So that is also one, I don't know, recent guideline I'm not read, but we do in practical current practice, in my practice, we give essential amino acids. Of course, here there is no keto analog, nothing, so we can safely give protein up to 8 gram or 1 gram per kg body weight, and we can treat this patient if needed. We can give more also if we are only targeting the liver regeneration. Your input.
Thank you, ma'am. Thank you. Mr. Khan, do you have to give any suggestions on this albumin?
Now, the same thing is that also, because there shouldn't be any protein restriction. If there is a kind of edema is not there, pityrial edema is not there, ascites is not there, so we can give the albumin, we can give the egg white also. If the patient is on Ryle's tube, maybe nasogastric or nasovaginal tube, in that cases we can use some kind of clinical supplementations which are available and which are research-based studies are there. We can give, but the patient is able to have orally. In that cases, there will be excess burden of the patient for making some supplementation, so it's not there. The normal regular food, normal regular diet with its albumin are present. We
Sorry,
can keep the
there will be no appetite, so patient will not be able to eat in this with the albumin or with the hepatitis or whatever the bilirubin is so high, and in renal also we lose appetite. So I don't think normal food in a required amount will be possible. So we will have to give supplement, and
supplements, yes,
will be the right choice of the formula.
Yes.
Your input, Geeta?
Yeah, I think you've said it, ma'am, and that's how we look at it. End of the day, appetite is major challenging. Proteins are not very easily digested by these patients because liver and kidney together with a challenge in appetite and looking at no weight loss, balancing the sarcopenia, there is a lot of challenge to maintain the appetite. So step one is look at the creat and liver values and go with the protein. And as you rightly said, branch in amino acids. Albumin is a byproduct of, it's an indication of a long-term malnutrition. I mean, it is somewhere, there's a lot of malnutrition and hence it's hypoalbuminuria. So as ma'am said, it's only an oncotic pressure which we generally look at an albumin support. Otherwise, managing the calories and giving some amount of protein supplements like essential amino acids and all should take care of these kind of patients is what even I feel. So I think a great discussion. We are actually running out of time. Can I take 2 more questions, ma'am? Or 1 more question, last question.
Some important questions, yes, you can.
The 3 foods which needs to be discussed in CKD, which has been highlighted. One is cranberry juice. I think a lot of discussion and phytonutrients, Mr. Khan, you also had mentioned. Nuts and lentils. So the question is, in these 3 areas of food, do we really have to, is there a recommendation? Is there any servings we can give? And how do we really balance the phosphates and other areas, proteins in these foods, potassium, etc.?
So if you ask me, no for cranberry juice.
Yes, same. I do second with Salami ma'am. There is no need for the cranberry juice extra kind of thing for any kind of kidney CKD patients or the liver patients, because this is no functional value for the cranberry juice in India, and we have to give in lot of artificial potassium, lot of artificial sodium, and a lot of artificial preservatives, additives, and also are there. This is number 1. And number 2, if you're someone is asking the lentils and all those things, because what I have discussed that those patients are vegetarian patients, those patients are unable to have any kind of non-veg products. For them, they can have lentils with the prescribed formula, but because lentils, number 1, have a very good amino acid, and number 2, it contains very good amount of the resistant maltodextrin. So resistant maltodextrin working very good tremendously in our large colon colonic epithelium, working as a prebiotics, and with the probiotics will act as the symbiotics, good for the gut health also, but not too much of the lentils because it's having a little bit of potassium and also phosphorus are there. So try to avoid lentils in dinner timing. Day timing will be okay. And nuts and all those things having high phosphorus, if the phosphorus level is okay, is the in the within the normal limitations in the biochemistry, they can have once in a blue moon, but non regularly in the kind of one feast or two feast of dry fruits, two feast of in a traditional way of a traditional diet or conventional diet is not required. But sometimes for the suffering from the kidney, I can't say anything. It's not like that. But you have to take everything. But moderation is the key, keeping in your mind. But cranberry juice is no for any kind of patients.
So thank you very much. I think we need another kidney session because participants are still not, they still feel that dil mange more. This is how I think.
Shomindu Ghosh has a question. Shomindu, do you have any question?
Geeta, I think
Yes, ma'am.
Mr. Khan said something about dairy product not to be given. I don't think I you.
No, dairy product can be given, I have said, because dairy products, what I have said that raw milk, sometimes patient have tendency in Kolkata, having 2 to 3 glasses of raw milk in daily and sometimes before the sleep, it's not recommended.
It's a boiled milk, is it?
Boiled milk, yes, boiled milk, but I have said that they can have paneer, they can have chena, and they can have curd made from the milk, but having milk like 2 or 3 times in a day, it's not required. Those are the high urea for the CKD patients.
We do allow milk if there is a fluid allowance available for our vegetarian patients to meet calcium and other requirement. The phosphorus content of milk and other foods. So this is your calculation, and you cannot say bluntly, no, okay, you will say only 2 servings. Calculating.
Noted. Sumendu Ghosh, I think, just commented, Mr. Khan, that it was a wonderful session rather than questioning. I think I was just going through the questions. So I think, ma'am, can we end the session?
Yes, please.
With your permission. Yeah. So thank you very much, Mr. Khan. I think dil mange more. This was not enough for us. We need more of renal sessions, and we will definitely look at it. The goal of this whole area of BNA in this year, we thought we'll talk about inflammation. We wanted to understand how an inflammation impacts kidneys, how an inflammation impacts liver. So I think we will take these discussions further going ahead, looking at inflammation as base and making case based. We would love to have you again, Mr. Khan. We will look at how the topic can be more customized to patient based. But today's session was very good. Thank you very much for giving a detailed perspective of your way of looking at CKD, because CKD, as Salome ma'am said, needs to be quantified as per the blood values, as per the patient requirements. So there's no blanket recommendations. It needs, when it comes to food like dals or dairy or all that, so we really would like it to quantify as a nutrition prescription. So that's the take back home message for all of us, and I assure all the participants that we will have more sessions. Over to you, ma'am.
Geeta, I want to thank Dr. Aritra for being on our platform. Thank you so much. Sorry we could not communicate. And I would like you to send me some details about how did you get this RD in clinical nutrition. There's a question, in fact, which I don't want to ask you. You can just give us, because we would like to know which association or who gives. I think this idea does not give. So just write to us. Okay? You can write.
There was a question. That when we introduced you, Mr. Khan, there was a question that what is registered clinical nutritionist and how do we get this license? So I think people are interested to know about it. So we look forward for your. You can mail or message us. I think we will take it forward.
Thank you so much.
Most thank you so much for inviting, and thank you so much for this lovely medical session. Thank you, Salome ma'am. Thank you, Dr. Geeta. Thank you, Naslin. And thank you all for your patient listening. Thank you. Good night.
Thank you very much. Yeah, ma'am, over to you for concluding remarks.
No, that's okay. You conclude and give thanks to the back-end team also.
Okay, thank you very much. Each participants who have joined today took out time, and it's indeed a great pleasure to keep meeting every month and talk about these kind of brainstorming clinical areas of nutrition and guidance from Salome ma'am, which is very, very integral part of these sessions. Experts come with a lot of topics and a lot of information, and we need to really put that information into our own way of looking at nutrition applications. So thank you very much, Mr. Khan, first of all, to take out time and accept our invitation. Thank you, Salome ma'am, as always. always be there for guiding us to work forward. Nazneen and Richa, a very important backbone for this kind of a BNA Live program which we conduct. And the backend team, Vishaka, who's been very, very integral part of communication and actually facilitating all this, and Mr. Date and Mr. Gandhi. And last and not the least, the participants to make it happen. Thank you very much. See you next month again. Give your feedback on the website of our BNA Live session, and also visit our page, Facebook and all, and give your comments. Let us know what sessions you're looking for, and we will be there for those speakers and sessions what you look for. Thank you very much.
There were some people who could not join. You can tell them about our YouTube.
So, being a Google Meet, I think only 100 participants were allowed. So, Mr. Khan, I think we had full attendance for this session. So, I think the speaker also makes an impact here. Thank you for that. And people who couldn't join next time can always go to our YouTube channel. Nazneen did mention that in the beginning, that you can, the same session is being surfaced on the YouTube channel. There are also videos. We can have the recording of this session also on our BNA Live website. All the previous recorded sessions are there. So I think you can visit those sites for the pre-recorded session. And next time, if you can't log in, you can go to the YouTube and be a part of this session. Thank you very much. Until then, next month, thank you. Bye-bye.
Thank you. Bye. Thank you so much.
Bye. Thank you. Bye.